Hi guys, so today I'll be talking about another topic, a gynecological history taking. Okay, so in my last video I have talked about obstetric history taking and then about obstetric examination. So here I'll go as first gynecological history taking, and then in my next video I'll be talking about gynecological examination. So you have an overall idea of how to take the OBS history taking, right? So there are some changes in gynecological history taking which I will be talking here. So hi, welcome to my channel Dr. Z, the AIIMSified WombWhisper. So as like in OBS history taking, in gyne history taking also there is some general principle, like you should be talking in patient's language so that the patient understands what question you are asking. You should build rapport with the patient. You should ensure privacy even when you are taking the history. Not only in examination, you should always ensure privacy in history taking also, and you should be respectful towards the patient, and you should avoid any judgment or any judgmental language. So the first thing is patient details, as in any history, so which includes name, age, husband's name, religion, address, education, occupation, socioeconomic condition, and parity status. So in OBS, I have told you the importance of each point, and in OBS history there was LMP, DD, POG, etc. But here you did not be mentioning that. You only mention the parity status, like if she is para 2 living 2, or she is nulli gravida, or she is postmenopausal. Okay, whatever you just mention here. Then comes chief complaints. So you should be writing 2 or 3 chief complaints in chronological order. Patient will be telling you 10 complaints, but you should pick up 2 or 3 important gynecological complaint of the patient. Like patient may tell you she has bleeding, PV or irregular menses, and she has bilateral lower limb pain, or she has headache, and she has pain during menstruation also. So what will you pick? You will pick heavy menstrual bleeding or irregular menstrual bleeding and pain during menstruation. Okay, and you record the chief complaints in patient's own words, like pain during menstruation, or heavy menstrual bleeding, or irregular bleeding, or discharge PV, or inability to conceive. Okay, and then comes the important part of the history, HOPI, history of present illness. So always start with like patient was apparently well till 2 years ago. If patient complains, she has heavy menstrual bleeding since last 2 years. So in history of present illness, you start with patient was apparently well 2 years ago. Then she started having heavy menstrual bleeding, which was, then you mention about the onset and duration. When did the problem, you ask patient when did her problem start, how was the onset, if it was sudden in onset or it was gradual in onset, as you ask in medicine and surgery history taking thing. So here also like that, you ask about the course of illness, if the bleeding had been continuous, or it is intermittent, or it is progressive, like initially it was less, but with each menstrual cycle it has increased in amount, or what. And if it persists in days or persists throughout the weeks or throughout the months, you ask that also. If there is any aggravating or relieving factor, like if it increases during exertion or doing household chores, or like during walking, like if any patient comes with symptoms of prolapse, like anything coming out of vagina, then her that symptom, that is something coming out of vagina, may increase during straining, like during chronic cough, or if she is lifting any heavy weight, or she is walking, or during when she is passing stool, then there is a strain, abdominal strain. So in that case prolapse may come out, and if she lies down, then it may goes in. So you mention it like that, if there is any aggravating or relieving factor. And what is relation to the menstrual cycle? If there is pain abdomen, so the pain abdomen is during menstruation, or just before onset of menstruation, or it persists throughout the month, like with menstruation and even without menstruation also. Relation with the coitus, if the pain abdomen is associated with coitus or not. And if there is any other associated symptoms, as urinary symptoms. You ask about if there is increase in urinary urgency, frequency, pain during micturition or burning sensation during micturition, or incontinence or feeling of retention of urine, like she feels like she has not voided all the urine and she needs to go again and again to evacuate the urine. If there is any gastrointestinal symptoms of constipation, bloating, if there is any systemic symptom, fever, loss of weight, loss of appetite, evening rise of temperature, anorexia, fatigue, generalized body ache. If there is metastasis symptoms, what is metastasis symptoms? If there is mets in the chest, in the lungs, then she may be having cough, hemoptysis, shortness of breath, breathlessness. If there is metastasis to the brain, then she may be having headache, blurring of vision, loss of consciousness. So you ask about metastatic symptoms like that, on loss of weight, loss of appetite. If there is metastasis to bowel or bladder, then there are the associated symptoms. So you ask about all these symptoms in relation to your chief complaints. All these may not be in each chief complaint, but you ask relevant to your chief complaints only. And your chief complaints is in chronological order, and when you explain your chief complaint in HOPI, it should also be in chronological order. Like if you are talking about heavy menstrual bleeding first, so you talk about all these symptoms related to heavy menstrual bleeding first, and then if her second chief complaint is inability to conceive, then you talk about infertility, HOPI. And HOPI is relating to each of these symptoms, like each of these cases, like AUB is one case, infertility is another case, prolapse is another case. So I will be talking about details of those HOPI in their relevant cases in further videos. Okay, so this is just general outlook, general format of HOPI. Next is you also ask about impact of those complaints or symptoms on her daily life. If it interferes with work, sleep, or her sexual life, if there were any emergency episodes in the past, like history of acute abdomen or syncope. Also ask about if she had taken any treatment related to her chief complaints, if she had taken any medication, or if there was any procedure done or any surgery done, or if there was any history of blood transfusion, and if she has responded to those treatment or not. Like patient may respond to some extent, or she may not respond at all. So ask about that also. And first mention the positive history, and then about the relevant negative history. Okay, like if you are suspecting in postmenopausal patient, if she comes with postmenopausal bleeding, then carcinoma, CA endometrium or CA cervix is one of the differentials. So you ask about the relevant positive history first, and then the negative history, like if there is no history of loss of weight, no history of loss of appetite. Okay. And what are the some common gynecological complaints which patient may present as their chief complaint? So there may be menstrual abnormality, there may be complaint of white discharge, there may be pain abdomen, mass per abdomen, there may be complaint of infertility or bleeding per vagina. Then comes next menstrual history after HOPI. So first there is patient details. Then there is chief complaint. Then comes history of present illness in details along with relevant negative history, and then comes menstrual history. Okay. So in menstrual history you start with age at menarche, when was her last menstrual period, about her cycle, about the flow, duration, interval, presence of any clots or dysmenorrhea. You ask about if there had been any abnormal bleeding pattern, if she is a known case of PCOS, if she has been using any hormonal medication, like if patient had been a case of PCOS, as you may see in a patient of infertility. So she may had been taking contraceptive pills like OCPs to regularize her menstruation earlier in the past. So ask her about that. And if the patient is menopausal, like postmenopausal, so ask about her perimenopausal period also, if it was smooth or she had problem of heavy bleeding during her perimenopausal period, and also ask about if there had been episodes of postmenopausal bleeding. No matter if it had not been even her chief complaint, if her complaint is anything else like mass per abdomen, still you need to ask about her postmenopausal bleeding status, if there had been any episode in the past, any single episode in the past. Then after menstrual history comes obstetric history. Like in OBS history taking, we take obstetric history in details, in past obstetric history in details, but in here you may not need to take everything in details, just you ask overall about her married status, and for she is married for how many years, her parity status, gravida won't be there, so you ask about her parity status, abortion and leaving issue. Then you ask about details of each pregnancy in short only, you need not explain it in details as in OBS, just ask about if there had been any issue or not. If not, then mention her antenatal and postnatal periods were uneventful, her delivery was cesarean or vaginal delivery, and if there had been any intrapartum complication. Also you can take contraceptive history along with obstetric history, or you can take it as a separate part also, but if you are taking it here, then you may remember this for long, otherwise we forget to take contraceptive history only. So it's better if you take it with this, if she had used any method of contraception in the past, for how much duration has she used, and if there was any complication along with the method used. If the patient is of prolapse, then in OBS history you have to take something history for something extra. What are those extra points? Inter-pregnancy interval, like if it was less than 2 years, or ideal interval is at least 2 years. So if it had been less than 2 years, like a year or 1.5 years, then that is a risk factor for prolapse. Also ask if it was home delivery, if there had been history of prolonged labor, history of any prolonged labor, if there was history of any birth injury or any early resumption of household work. Many women who undergo home delivery, they may resume to household work early, so that is a risk factor for prolapse. So in case of prolapse patient, you have to take this history extra, otherwise in OBS history you did not be taking this in all other cases. And also ask about history of tubal ligation. Why it is important? Because salpingectomy, there is risk reducing salpingectomy if you know about stick lesion. Like earlier it was not been in in our knowledge that the ovarian or peritoneal cancer arises from the fimbrial end of the fallopian tube, but now in recent years it has been there in the books also, like the source of majority of the ovarian cancer are from the fimbrial end of the fallopian tube. So if you eliminate the fallopian tube, then the risk of ovarian cancer reduces by 90%. So in case of tubectomy patient, even though all the length of the tube has not been removed, but a part has been removed, and that may lead to reduction in the cases of ovarian cancer. So it is important to take the tubal ligation status also. Now comes the past history. So ask about any medical disorder, hypertension, diabetes, tuberculosis, thyroid disorder or heart disease. You also ask about any surgical history in the past, if there had been any abdominal or pelvic surgeries, if there had been any blood transfusion in the past, if there is any history of chronic medication use, or any history of previous pelvic infections or sexually transmitted infections in the patient. It is important in gynae patients. So here it is. In family history, ask about history of diabetes, hypertension, TB, malignancy. Malignancy is important because these cancer may history of this cancer in family is a risk factor for endometrial, ovarian or breast cancer in our patient. History of tuning and genetic disorder you can also ask, but it's more important in OBS patient. Then personal history, ask about diet, sleep, appetite, bowel, bladder habits, any addiction or allergies. This one is extra. history of cervical cancer screening or vaccination in the past. You can take this in past history also, and you can take this in personal history also. Similarly, contraceptive use, you can take it in obstetric history or in personal history. Also ask about socioeconomic status of the patient. Treatment history, you can take it in HOPI. It is better if you take it in HOPI, and if not, then you can take it as a separate part. Ask about current medication, if she had any previous hospital visit or any previous procedure or surgery, and how she has responded to the previous treatment. Like, it is more important in infertility patient. Many times they take ovulation inductions or like IUI, IVF outside, and then after visiting many centers they may come to your center for evaluation again. So it is important in infertility patient. And there is one more part which is of utmost important in infertility patient, that is husband's history. You may not be taking it in other other patients who present with other symptoms, but in patients of infertility you have to take this history, which includes what is her age of marriage and what is her age of cohabitation. A patient may be married for 10 years, but she may be trying for conception only for a year. So age of cohabitation is also very important. Ask about the age of the husband, his occupation, education, because suppose if he is exposed to some radio agents or any chemo agents, or maybe working in a dye industry, then that may be toxic to the gonads. So it is very important to ask about occupation of the husband. Also ask about if he had any comorbidities or he is suffering from any comorbidity at present, if he had any past surgeries or not. And also ask about coital frequency, if they are aware of the fertile period or not. If during coitus, if her husband or she faces any problem, like her husband may be facing premature ejaculation or retrograde ejaculation, or if she faces any complaint of dyspareunia or vaginismus, like that. So ask about that also. And if there is history of this is very sensitive to ask, but you have to ask it, like history of multiple partners or not. And at the end of the history, always try to present a small summary based on your history. So here I have given just one example, like Mrs. X, 67 years old, wife of Mr. B, Hindu by religion, a graduate, a housewife belonging to upper middle class, and she is postmenopausal since last 15 years with known case of hypertension and diabetes with postmenopausal bleeding. So here are all the patient details, her parity status, her menopausal status, her important past medical history, and her at last you tell about her chief complaints. So this is how gynecological history taking should be. So thank you for watching this video. In next video I will be talking about gynecological examination. Thank you.